I'm actually going to take a very micro kind of approach, probably sort of influenced quite a bit by my background, which is really, I'm a physician, and really got trained initially in clinical epidemiology and randomized trials, and only got into health services research and health policy in the sort of latter half of my waning career. So that's sort of the perspective I bring to this. And so I have 3 or 5 fairly specific answers to, I mean, obviously there's lots left to be discovered, but what my top 5 from my perspective might be. So number 1, how to integrate research into policymaking in real time. And the emphasis here, I think the challenge of figuring out how to do it is the in real time. And I may be wrong, but my sense is that we spend a lot of time as sort of saying, okay, we're going to do a policy change, we're going to reform how we sort of design primary care, we're going to do that over 5 years, then we're going to have a period of 2 years of evaluation, and then we're going to move forward. And by the time you're into the 4th year of the primary care reform, people are usually starting to think of, well, some things are working well, some things aren't, we got to change it. And actually, you don't have the time to wait for that extra 2 to 3 years. So I think there's a real, some of that is, a micro part of that is related to the delay that we have in getting some data. So when I used to work at ISIS, I mean, Cahspr data, came generally sort of 18 months later sometimes than the actual event. But I think more importantly, it's our sort of philosophy of doing something and then evaluating it. And I think we need to move to having evaluators involved with policymakers at the very beginning when a major policy is being considered, and working as part of that team so that they're doing an evaluation and research as part integrally and not just waiting to the end and then evaluating it. So that would be number 1. Number 2 is how to involve patients in health policy research and how to involve patients in priority setting. I had the pleasure of visiting the James Lind Alliance, and if none of you are aware of it, I highly suggest you have a look at their website. It's actually founded by Ian Chalmers, who's the person that founded the Cochrane collaboration, and it's dedicated to involving patients and their caregivers in setting research priorities. So they basically have and when I visited them, I was actually kind of blown away. It was much more developed than I thought it would be. And they have actually a fairly standardized process now that takes about a year. I mean, let's use an example, multiple sclerosis or rheumatoid arthritis. You get patients and their caregivers with RA together, and you ask them, what are the uncertainties in your care, in your life that you would want research to answer for you? And they have a process that works quite well to develop, actually, instead of the top 5, it's the top 10 from the patient and caregiver's perspective. And not surprisingly, often it's very similar to what the clinicians say, but in very important ways it can be quite different. So that patients, for example, are much more focused on fatigue, actually, it turned out, with RA, and not just pain. And I've often wondered whether we should be doing the same kind of thing with our health services research. I mean, it's us in this room that are deciding what the research priorities are to reforming our healthcare system. And I sit on Robin's advisory board, and there's actually, I would argue, no actual patients on that board. And I'm not sure that's necessarily the place where it needs to happen, but wouldn't it be interesting to see whether you could do a modified James Lind Alliance process, not around patients with a specific disease, but around people that use a particular healthcare system and say, hey, what are the things that you would really want to have fixed that maybe we need some research to figure out how to best do that? So that's number 2. And the answer may be that it doesn't work, but it would be nice to know one way or the other, it seems to me. Number 3 is how to increase the public's use of public reporting, or to find out that we should just basically decide that public reporting isn't that useful. So I've always been struck myself that I sort of have a passionate, intuitive belief that if we publicly reported how our hospitals do, well, let's just use that as the example, that would be important to the public. But my read, and I'm not a total expert in this, but my read of the literature is that most of the literature, surprisingly, says actually has relatively little impact upon the public, and that the reporting has more of an impact upon healthcare providers, actually, who decide where they're going to refer people. But there's a part of me that's still concerned about that that research, because my gut sense is we actually haven't asked the public, what do you really want reported? And we haven't asked them, how would it be useful for you to have it reported? So that, you know, if I went on St. Michael's Hospital's, my hospital's website to try and find the publicly reported stuff, it would take me quite a while just to find it. So it's not surprising to me that it hasn't had much of an impact. But to me, I mean, it's interesting, quite a number of the panelists have talked about engaging the public. I mean, I think engaging the public takes time and effort like anything else. And I think it would be important to know how best to do it and, you know, what its impacts are and is it really kind of worth it. And so I would have thought, you know, for example, using Kai-Hi's recent report on hospital performance across the country, sort of, you know, are they reporting outcomes that patients really care about? Or are they missing, I'm sure they do care about 30-day mortality, but are they missing important things that patients care about? Are they presenting it in such a way that patients can understand it and access it? And are we helping patients actually be able to use it in a real useful way? Number 4, this is actually quite micro and has actually come out of, I live in Ontario, so I'm reading the newspapers about the rather nasty sort of relationship between the Ontario Medical Association and our Ministry of Health right now. But it's developing effective methods of improving the appropriateness of diagnostic testing. We've been talking about this like forever. I did my master's thesis at Mac in 1986 on trying to figure out a project on the appropriateness of ordering MRI scans for people with headache. I mean, I could redo that thesis now. And it seems to me that actually a considerable amount of the debate between, it's more than a debate, between the OMA and the ministry actually is around just that. I mean, the ministry is saying we're not going to be paying for as many echoes. We're not going to be, we want you folks to be ordering more responsibly or more appropriately. And it seems to me that as a health services research community, we actually haven't taken that on. And I was thinking as Steny was talking about the, you know, I wrote it down here, Steny. It's complicated and it will take a long time. Is my reaction to that, to the issue of developing effective methods of improving the appropriateness of diagnostic testing is that it is an incredibly complex issue. It involves patient expectations, patient understanding of what diagnostic tests are likely to do. It involves, I think, educating our medical students so that they don't think the appropriate workup is always a total full workup. It involves all sorts of stuff. And I do think that's a 10 to 15 year, not just research agenda. It doesn't mean we can't bite off measurable things along the way, but I do think that's an incredibly complex one that is very, very multidisciplinary, and I think very relevant, at least in the province that I live. And then finally, number 5 for me is developing effective governance models that improve physician accountability, performance, and job satisfaction. So I'm sort of struck by, you know, there's a lot of focus on doc salaries, and we do get paid quite well, but we also, though, I think almost as importantly, rightly or wrongly, we drive a lot of what happens in the rest of the system, never mind our salaries. So we order the tests, we do the procedures. So what we as docs do affects way more than the 18 to 20% of the healthcare budget that is our salaries. And my observation would be, in general, I don't think physicians are as engaged in the governance of the healthcare system as other folks. At my hospital, if you do a quality improvement initiative and have a meeting, I can almost guarantee you that the group that will have the lowest representation there are the docs. You know, docs that work in hospitals are generally actually don't work for the hospital. And I'm not suggesting we need to get into a kind of hierarchical governance model, but I do think, and the other observation I would make is that my sense is that at least in Ontario, physicians are actually incredibly independent in terms of what they're able to order, what they're able to do. But my observation of talking to my colleagues is we're not happy. I think we're a little grumpier and less happy than we were before, despite the fact that we're making quite a good salary and we are quite independent. And I think it's a sense that the system isn't working as well as it should. And the real question to me, a really important question is, how do you develop a governance model that actually increases docs' satisfaction with their job, but does integrate them a bit more, I think, into the healthcare system, its governance, and its accountability. Thanks very much.